Ouais. Ugh. Mhm. Hmm. Hey, Dr. Sbeih, how you doing?
Hello,
Can you
John.
hear-
How are you?
You can hear me okay?
Yeah, good. You've been busy today, yeah?
Yeah, let me just change this background here.
Sure.
So how you been? You been busy?
I'm very busy. You?
Yeah. Busy or we're trying to make a connection to Barrow.
Right.
We'd like to televise a couple of their webcasts a month.
Sure.
Specifically for different levels of training, like for residents and
Absolutely.
students,
Absolutely.
and maybe for neurosurgeons. I got to convince them.
Yeah.
They have the expertise. They have the manpower. I think they just need a little focus and direction.
Absolutely. How's the weather in Miami?
I'm sorry.
How's the weather in Miami?
Miami is hot, but I don't mind. I like it hot. So, are you traveling? Looks. Oh, you're in your auditorium, right?
Yeah, exactly.
Oh, okay. Dr. Gabulo, are you there? We just did a webcast from Africa. And we'd like to start doing more of those. So how's your assistant there? Is he, I guess there he is in the background, right? No, that's not him.
Yeah, this is my secretary.
Yeah, he's a tech that helps you, right?
Yeah, he is. Yeah.
He's still with you, huh?
Two of them.
Three.
Yeah, two secretaries.
Oh, okay. So are you doing any webcasting at all? Or no?
Yeah, but what's locally, but now it's, we've been doing this, as you know, about 30 years of teaching.
Yeah.
And with you, we've been about 4 years now, Joe.
Yeah, excuse me. Here, just for a minute. Hello? Yeah. How are you doing?
But
People will drop in as we go along.
Sure.
Dr. Gabulo, you back yet? Have you met Dr. Gabulo from Congo?
Yeah, of course.
Yes,
Oh, yeah, I think he's been to a couple of, you remember Dr. Sbeih,
yes,
right?
Dr. Bennett.
Yeah,
Hello, Professor Ibrahim.
Hello.
Yes, how are you, my professor?
No, I'm fine. How are you?
Fine, thanks. Dr. Bennett, I was in Amman in 2017, so I learned a lot from Professor Sbeih with Professor Dolan.
Yeah, you were saying you went to the lab, right? Way back then?
Yes, yes.
And the lab's still going, right?
Yes,
It's one of the few labs in the Middle East, right?
very, very few.
Very
Very few labs. Yeah, that's pretty good. Okay, let's start. The people will come along. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett broadcasting from Amman, Jordan. We're restarting the Jordan Neurosurgical Grand Rounds with a well-known, longtime teacher in the Middle East and the rest of the world, Dr. Ibrahim Sbeih. And we welcome him back, and it's all yours, Dr. Sbeih.
Hello. Hello, everybody. It's nice to see you all again. People here in the auditorium and people abroad. And it's my pleasure to be transmitting from the Farah Medical Campus here in Amman, Jordan. What triggered the presentation this week is that 3 weeks ago, we had a patient, 37-year-old patient, a male patient from Iraq, who came with this lesion, which we could not tell whether this is a meningioma or a meningopericytoma. So this was his MRI, and this was his CT angiography and CT venography. And can you hear me? So this was the CT angiogram and venogram, lots of blood vessels. We were not sure whether this is a meningioma or a meningopericytoma. Anyway, we operated upon him. This is during surgery. I decided to take it in toto rather than in piecemeal, and that's the tumor, that's the specimen which we sent for our histopathologist to Faisal. The patient did well, had no deficits, and beautiful post-operative MRI showing total tumor removal. However, we debated whether this is a meningioma or hemangiopericystoma, but again, the last say would be from the histopathologist, and our histopathologist, Dr. Hassan Al-Farsa, decided that this is angiomatous meningioma. So that's what triggered this presentation today. Let's look back at the hemangiopericytomas. So today we're going to talk about hemangiopericystoma from the clinical, radiological, operative, and pathological correlation. Let me take you back to prior to 1993. Before that, the hemangiopericystoma were considered as angioplastic variant of meningioma, so no difference. You don't speak about hemangiopericystoma, you speak about angioplastic meningioma. 93, no. Hemangiopericystoma is different from meningioma. That's the WHO classification. Another tumor came along to confuse with the hemangiopericystoma. So is this hemangiopericystoma or meningioma? Is this hemangiopericystoma or solitary fibrous tumor? Again, this tumor is old enough, being described back in 1931. So the WHO classification 2002 and 2007 decided there are two distinct entities. Solitary fibrous tumor is different from the hemangiopericystoma. 2016, WHO decided we will give the combined term SFT, solitary fibrous tumor, and then a slash hemangiopericytoma. 2021, the last WHO classification of brain tumors. They looked at the classification and they decided both are the same. Solitary fibrous tumor is the same like hemangiopericytoma with 3 grades, grade 1, grade 2, and grade 3. Grade 1, you could say this was the old solitary fibrous tumor. Grade 2, you could say this was the old hemangiopericytoma. Grade 3 is anaplastic hemangiopericytoma. So you can see now that hemangiopericytoma does not exist. It is obsolete. If you speak about hemangiopericytoma, solitary fibrous tumor. So what is solitary fibrous tumor hemangiopericytoma, the new terminology? It is malignant transformation of pericytes. And what are these pericytes? They are called Zimmermann pericytes. Zimmermann, who discovered them. It's a contractile mesenchymal perivascular cell, which is around the wall of the capillaries and the postcapillary venules. And the idea that this cell is contractile to give some character to these results. And they are present in every part of your body, not in the meninges, only every part of your body. Why did I put this? You would be following the Crown series on TV. And you would remember that the royal family would go to Scotland for hunting deers, hunting the stag horn in the Scotland High. They are stag because this picture is there. It's different types of horns. And there is also stag horn plants. So this picture, because it is similar to the blood vessels in the solitary fibrous tumor hemangiopericytoma, is called the stag horn cells. And I think Dr. Parsak will allude to this later. So these tumors, characterized by the stag horn vessels, they look like the stag horn, the deer, and they are perivascular. I ask you, Dr. Parsak, to come over and tell us more about the histopathology of these tumors.
Good afternoon, everybody. I'm Dr. Hussam Abu Farsak, pathologist, First Medical Lab Pathology. This is the case that we're presenting. You can see the hemangiopericytoma in this case is very cellular, a tumor. The blood vessels is so much blood vessels there, but they are not typical in this case of Staghorn. And not every case of hemangiopericytoma will have a typical. But if you don't see it, that does not rule it out. But you can see so many blood vessels, and you can imagine how much would be vascular during surgery. You can see the blood vessels here, so many of them, and usually it's dura-based tumor. It originates from the dura as meningioma. So this is another tumor that also originates from the dura. Typically, these are the spindle to oval shaped tumor cells. There could be hyperchromasia. There could be mitosis also. These originate from pericytes, not endothelial cells. Pericytes. Pericytes are the cells that wrap endothelial cells in all blood vessels, to make them to more contract and help in the blood-brain barriers. In hemangiopericytoma, mitosis is very important. If mitosis is 5 or more, that were 10 high power field, we call it anaplastic or grade 3. If it is less, it is grade 2. And if there is no necrosis, also in grade 2. And so mitosis and necrosis both are important. This is one of the mitotic figures also in the case that Dr. Ibrahim will present. And these are typical the pericytes. You can see their shape is irregular. They tend to be oval, but all these are blood endothelial cells in between them. So they proliferate, and there's a lot of blood vessels. We'll show this by the immuno. This case was embolized because to operate on hemangiopericytoma or vascular, probably you need to decrease the vascularity, and you can see the material embolization, and probably somebody can allude more on this feature. In this case, there was an area of necrosis, but probably this is because of the embolization that was performed. And you can see how much vascularity in the tumor. It's very, very vascular. There was brain invasion. You can see this is the brain and this is the tumor. And hemangioperocytoma is known for brain invasion, and this is the material that was embolized in the blood vessels. And you can see more the black material, the embolized material in the blood vessels in the brain tissue. Hemangioperocytoma has a definite immune staining pattern that differentiates it from meningioma, and this is very important. CD34 is one of the most important blood markers in hemangioperocytoma because it's positive in all cells, while in meningioma it's only positive in the endothelial cells. EMA, on the contrary, is negative completely in hemangioperocytoma, while it's positive in meningioma. So when you see this pattern, you strongly suspect this is hemangioperocytoma. Progesterone is negative in hemangioperocytoma, while it's positive in meningioma. P53 can be positive in meningioma or hemangioperocytoma when it is anaplastic. Ki67 is usually high in hemangioperocytoma, higher than in meningioma, and in this case it was 5%. This is a very important stain. Now we use it from 2018 onward. We start to use it called STAT6, and you can see this is a nuclear stain. And when you see something nuclear, this is probably related to genetic fusion. There's a fusion between NAB2 and STAT6 in chromosome 16 that produce the tumor, which is the hemangioperocytoma. And the brown staining of the nuclei is usually indicate that it is positive. And this is considered specific and sensitive for hemangioperocytoma. So if you see a tumor that you want to know whether it is hemangioperocytoma or solitary fibrous tumor, both of them are positive for STAT6, while it is negative in other tumors and negative in meningioma. This case, just to show you, this is not the same patient. So show you some of the staghorn appearance, vascularity, and this is more of the staghorn appearance of the tumor. So the tumor usually in hemangioperocytoma is usually have this staghorn appearance because the pericytes originate around it and they push it to become staghorn. So this is these are the features of hemangioperocytoma. Thank you.
Are you okay, Doc?
Okay, so
We lost the audio there.
hello? Can you hear me, Joe?
Oh, yes.
Okay. So these tumors, as you said, the new terminology, solitary fibrous tumor hemangioperocytoma, are rare. So much that no single institution in the world is likely to have a large enough series to answer all the relevant questions. This is one paper from the American Journal of Clinical Oncology, recent one, 2014. They looked at 15 clinical studies over 30 years. There were only 523 patients all around the world. These kinds of tumors, solitary fibrous tumor / hemangioperocytoma, are more in adults, less in children, and when they are in children, they are more benign. Meningioma is known to be common in females. Solitary fibrous tumor hemangioperocytoma is definitely more in males. This is a difference. They are highly aggressive. So meningioma are 3 types: grade 1 benign, grade 2 medium, and grade 3 the malignancies. These are highly aggressive meningeal tumors with tendency for recurrence and metastasis. That's why it's important to try to differentiate between meningioma and hemangioperocytoma. the old terminology. So they are considered to be highly liable for recurrence, 50 to 90%. 50 to 90% of patients, they have recurrence. To metastasize outside the brain, 15 to 35%. So this is a dangerous tumor. Multiple recurrences, multiple metastases. Removed here, came back again, removed, came back again, and so on. First recurrence, second recurrence, third recurrence. So think of hemangioperitocytoma as bad tumor. Multiple surgeries with radiotherapy, with chemotherapy, still it comes back. And this recurrence, as I said, can occur at the primary site, or it can occur as seedling in the rectomeningeal or distant metastases. Let's look at this. What is the chance of recurrence after 5, 10, and 15? After 5 years, recurrence is 65%. After 10 years, 76% more. After 15 years, very high. An example of tumor that was removed and then it occurred with metastasis here in the liver. Hemangioperitocytoma metastasizing liver. So, solitary fibrous tumors, hemangioperitocytoma, as I said, they are coming from Zimmerman pericytes, which are around the capillaries and the neurons to make them contract, and they are present in any part of your brain. So it is not limited to the brain. But let's look at the brain first. More in supratentorial than infratentorial, less than in the spinal canal. This is one of them, solitary hemangioperitocytoma fibrous tumor in parietal bone. Could be cortical, looks like a meningioma. Parasagittal, common site. So you confuse them with meningiomas. Cranial base, this is a paper from China, a recent one, 2022, looking at the solitary fibrous tumor coming in the skull base. This is in the anterior fossa. When you look at this, you would think this is it's actually meningioma. But looking again here, lots of blood vessels inside can give you the clue. And the temporal fossa, the middle fossa, again, you can miss this as sphenoid meningioma. External ear, for the ENT people here in the audience, external ear hemangioperitocytoma. And they are richly blood supply. They could be supplied from the external carotid, the internal carotid, vertebrobasilar, and so on. So this is one case supplied by middle meningeal and by the vertebral artery. Orbit, they can occur in the orbit, and you can miss them for cavernomas. Sphenoid wing, miss them as sphenoid wing meningioma. Cerebellopontine angle is for the German staff. Not everything in the cerebellopontine angle is distillation. There are 30 pathologists there, more than 30. By the way, this one's coming from Tunisia, 2016. From Australia, trigeminal nerve specific on the skull base. Again, you can think of this as a trigeminal schwannoma or proclavian meningioma and so on. It could be transtentorial, supratentorial, and infratentorial. It could be in the spine, as we said. This is in the cervical spine. Recent paper from Germany. Another paper from South Korea with this tumor inside the canal and their operative findings. Could be in the sacrum. So remember, these tumors can occur anywhere. If they occur in the brain, more supratentorially than infratentorially, and more so than in the spine. Other parts of the body, we said external canal of the ear, they can occur like this one in the conjunctiva. In the liver, isolated, just in the liver. So how they look from the radiology point of view? We do CT scan, lots of calcification, and you can see lots of destruction in the wall. they are aggressive tumors. So CT scan like this, as you said. If you do MRI, this is T1. This is T1 with contrast. You can see the difference here. Lots of contrast, lots of visual void. And this is T2. And this is diffusion weighted ADC. Diffusion weighted, there is restriction, and the ADC is different than in meningiomas. So typical appearance of aggressive solitary fibrous tumor in meningoperitocytoma. If you do SWI weighted images, you can see lots of vessels and veins inside. Again, this is a very vascular tumor. Let's try to differentiate between meningioma and specific angiomatous meningioma and the solitary fibrous meningoperitocytoma. Both they have good contrast, but the more nodules are more in the pericytoma. More edema in the meningioma, the same in the solitary fibrous tumor, but to a lesser degree. Diffusion weighted both show restriction, but lower figures in the hemangiopericytoma. And this is recently has been considered as point of differentiation. Meningioma, T1 with contrast, as I said. By the way, it could be related to the dura, it could be isolated from the dura, because your mesenchymal cells are not only in the meninges, are also inside. T2, the edema, as I said, less edema in the hemangiopericytoma group, and difference in the ADC between the meningioma and the solitary fibrous tumor. What is the treatment of these cases? You may treat them by embolization, as we'll see in our case. There is richer blood supply from the external carotid, from the carotid itself, internal carotid, middle cerebral, anterior cerebral, basilar, vertebral, you name it. So people are afraid to embolize because the embolus may go into the brain arteries, then you can cause problems. Example, this case being supplied from the occipital artery, a branch from the external carotid, and also supplied by ICA and cerebrocerebellar artery. This paper about preoperative embolization of intracranial meningoperitocytomas. Is it controversial? Yes, it is. Very lots of controversy regarding embolization of meningioma or meningoperitocytoma. You have to be careful. And Dr. Farid, who just arrived, may interfere and tell us more about this. So the treatment of these cases, what is the best treatment? Radical surgical excision is always the golden rule. Radiation is radiation. Radiation in the past, in the future, presently, it is some added treatment, some palliative treatment. You give it for patients who you cannot operate upon. People label me as anti-radiation. I'm not. I'm anti-abuse of radiation. So surgical excision, yeah, you can follow that with radiotherapy, chemotherapy, because they are malignant tumors. You can give them early or late. You can use any type of radiation, conventional, external beam, intensity modulated, or radiosurgery. They are sometimes sensitive to radiosurgery. You give them for recurrent or residual tumors. As I said, I'm an expert in MRI. I had my training for 6 months in Karolinska in Sweden. And this is the first machine in the Middle East. And this is the very first case that I treated back in '96. So when I speak about gamma, I know as an expert what to say. Some cases treated by radiosurgery. So your aim is not to vanish the tumor. Your aim is just to stabilize the tumor. And you're happy if it gets smaller. But if you need to operate because they did not respond, then God help you, because surgery would be 100 times more difficult. This is a paper from Sheehan in Virginia, famous center for radiosurgery. And this is, for them, is a good treatment. For the patient, it's not. Tumor is still there. Cyper knife can be used. So whatever radiation, it is radiation. Can chemotherapy help us here? Questionable. Lots of regimes can be given, but they've been disappointing. So combination, one single drug, etc. Temozolomide is still there with other drugs. They show this case where the tumor is there in the lung and getting smaller with just the chemotherapy. What's the outcome of these tumors? Bad. Mortality is high, 35%. Recurrence, as we said, 55% within 5 years. Metastasis is more than 20%. Let's look at the overall survival. You don't look at the recurrence period, you look at the overall survival. 5 years, overall survival 85, 10 years, only 35% are still alive. This paper from Neil Kitchen, a colleague of mine from London, putting his cases, 39 patients, most of them are cranial, overall survival is a little better than the current data. But again, few people are still alive here. Case presentation of today is this lady, 45-year-old female lady from Jordan. We are back in 2016, I think, not 17. It is a transtentorial solitary fibrous tumor. This picture is from Yazerville book. This is how he classified the tentorial lesions. He said there are medial, there are lateral, and there are intermediate. Some around the hiatus, some are not. So if you applied this on the lesions, then you would understand what's going on. She complained of 4 months worth of difficulty to perform fine movements, meaning that she has pyramidal weakness, right tinnitus and dizziness, right-sided weakness, imbalance veering to the right. Glasgow Coma scale was normal, mental state normal. She was a little bit dysarthric. She had a little bit of weakness in her upper and lower limbs, 4+/5, and she had 6 nerve palsy on the right side. This is the lady. In fact, here you don't see the 6 nerve palsy because she was given steroids and the 6 nerve palsy improved just before surgery. But she had all the cerebellar signs. So her images back, as I said, it's 2016, not 17. This is her CT scan. You can see you are starting in the posterior fossa, going up with lots of vessels inside, reaching to the vitreous bone, above the vitreous bone, and then up to the temporal of the fossa. This is the CT scan, which is a little bit writing green. MRI, lots of vessels, vessel void. Contrast, lots of vessel void. T2, look at the compression of the cerebellum and the brainstem. Lots of blood vessels. Lots of blood vessels. And this is the diffusion on the ATC. Restriction with low values. The coronal view, you can see the edge of the tint here. And you can see the edge of the tint. So it is transtentorial. Frightening. I really, deep inside me, I wish that this lady would go away, but she insisted on me. I was in trouble. I had to accept their trust in me. Anyways, looking at the MRI, I thought this is very, very vascular in a very dangerous area. So is Hazem here? Hazem? Oh. Dr. Hazem Habub is an interventional radiologist, and he will tell you about the procedure.
Okay, from the MRI study, it shows that this is a vascular tumor, typical. It shows mixed features like meningioma. They are all have tentorial tails and they are vascular. It depends on how much they are taking from bile, dural branches of the maternal and vertebral artery. This is what determines the success rate. And there is a lot of papers that describe the difference in success rate of embolization of hemangiopericytomas or solitary fiber tumor, depending on the location of embolization. So in this case, I think we went into two different branches. This is the on the left-hand side, you can see the external carotid angiogram, and it shows that there is tremendous flow or vascularity to the tumor from the occipital artery. So if I can use this. It takes a good amount of blood supply from the transosseous. This is transosseous branch of the occipital artery. It also has some branches from the ascending pharyngeal artery. It has branches from foraminal dural arteries of the external carotid artery. Probably it takes from the posterior auricular as well, or it's just having some angiogenesis from the posterior auricular. And this is the late phase of the angiogram. It shows the complete enhancement of parenchymogram. What we see, this is called the parenchymogram. You can see that there's probably another. This is most likely post-embolization, because there are casts in the vessels here and there. So probably we have injected from the ascending pharyngeal from. I don't see if we injected from the current middle meningeal or from the middle meningeal itself, because it takes a lot of blood supply from this. The concept of treatment of this tumor is really depends on your understanding of the backfilling, what they call it, the pile backfilling. If you can, especially when these tumors, they are supplied from the internal and vertebral as well, but you have still a minimal supply from the external carotid artery. So, like 65% of these tumors, they have blood supply directly pile branches of the internal carotid artery or vertebrovascular system, and this is make it very difficult for embolization and very of high complications. So you have to depend on having a dural branch from the external carotid artery, even if it's minimal supply. And then you have the concept of pile backfilling, which means that you wedge your catheter in the dural branch and you just keep pushing the liquid embolic to build the pressure, and then you fill back the pile branches of the internal or the vertebral branches. Like in this case, this is typical supply from the transosseous branch of the occipital artery, which is this one. So we were targeting this vessel, and this is the most of the catheter. This is a catheter what we call, which has 3 marks, which is a detachable catheter. So you can put your liquid embolic material, and at the end you leave the distal part of the catheter in the native artery. So in here you can see that there was a complete, almost complete. You never reach a complete cast of filling of the whole vessels feeding from different parts. This is the bright or the whitish lines are the cast of the embolic material in the tumor, and you can see that they have extended to the branches from the internal maxillary artery even, and filling all the branches of the ascending pharyngeal, just giving that injection from the transosseous branch of the occipital artery. This is another. Sorry, this is probably another branch. It's a recurrent meningeal branch of the middle meningeal artery, and it shows that it enhances the dural part and then the superior part of the tumor, and then you can also do the same thing, trying to backfill the embolic material into the whole tumor parenchymogram, which means that these are the small pile supplies from different parts, from internal, from basilar, as well as from the external dural branches. So this is what you do in essence. You try to fill as much of the tumor pile branches from the. This is the internal carotid angiogram. It shows minimal filling from the dural branches of the internal carotid artery here to that side. This is the AP and lateral view. The same thing, it has, this tumor has some supply from this dural branch of the internal carotid artery. The meningohypophyseal. So this is at the end, when we inject from the external, we did not go into the meningohypophyseal. Very, very difficult to go and to cannulate this branch. So just keep filling from the external carotid or from the meningeal. You can backfill. This is what we call the backfilling of the pyodural branches. So you backfill the artery and then you stop the supply from the meningeal branches and internal carotid artery. The same thing if it has supply from the basilar, you just keep filling as well from wherever you are. If you can just keep filling the pile branches. So at the end, I think there was more like 80, what they call the devascularization percentage. Now they have scale for them for the devascularization percentage. So I think this was like 70–80% devascularization percent. I'd like to note that one of the papers Dr. Sbeih mentioned from Hunak, I think, they published another series in 2019. They will to see the value of embolization, and it was definitely very valuable for intraoperative loss, and then it's very valuable for reducing the recurrence as well. He's from Yemen. He's from Yemen. In this case, it's very obvious. It's the new material, the liquid, what we call the liquid. This is like Minox, Onyx, all this variant, it's the same. It's liquid embolic. It's not glue. If it was glue, it would have been segmented a lot, but the beauty of this new material is the continuity of filling slightly. Now we use Minox prototype for this. The chance of having the this. Can you come over here, please? Cooperation with Dr. Hassan and Dr. Farid, with our colleagues and friends. And I'd like to remove your idea of embolization of meningioma.
Thank you, Dr. Ibrahim. Topic that is hard to cover in a small comment or short comment, but I have to congratulate Dr. Hazem for this nicely done embolization procedure. This is very nice filling of a tumor. In general, I think the decision for the value of embolization of any tumor preoperatively, that value is judged by the surgeon who will be doing the surgery. So clearly, everything we do has significant risks. Even this, people sometimes underestimate an external carotid artery embolization. This procedure has, especially like this one, has significant risk for cranial nerve pulses, which obviously is part of any procedure we do. So the value of these preoperative embolization has to be decided by the surgeon who's doing it, and decide if essentially controlling these supplying vessels is possible intraoperatively or not. This is clearly a very challenging place for to be approached without preoperative embolization, considering the location of the tumor at the skull base and all these multiple branches. So this is clearly smartly judged by Dr. Ibrahim at that time that this needs the treatment. However, if you are dealing with a convexity small hemangioma, very few people will support preoperative embolization in these patients, because most surgeons will feel very comfortable controlling the blood supply to these tumors without the added risks of the preoperative embolization. So in short, I would say it is decided case by case basis based on the location, the type of the tumor, and the risk-benefit ratio for each location, and in the hands of the surgeon. Some people, obviously, and you see this issue when you're dealing with AVMs. A lot of people in the world resect AVMs without preoperative embolization, which is the most vascular part of any tumor you could approach. So the idea that you need definitely always preoperative embolization is not valid, because clearly AVMs are resected in the expert site without embolizing them. So that's my notes about it. Thank you.
Also, we have not to forget that embolization carries the risk of the procedure itself, the geography, and the embolic material getting stray in the blocked arteries or veins or damage to cranial nerves. Okay, we'll continue. And now we decided that this is surgery and we get embolization. To go there, you have to have good anatomical knowledge. If you don't go there. You have to have good, deep, delicate surgical anatomical knowledge. Let's look at that. This is the folks and this is the tent. This area of the tent is richly blood supplied. Supplied by the ascending pharyngeal artery, branch of the external carotid. And this is one case of mine where the ascending pharyngeal is supplying the tumor. So look at the tent, as I said, it is richly blood supplied. Here you have the medial tentorial artery, and you have the lateral tentorial artery, and you have a branch from the posterior meningeal artery, which is coming from the vertebra. Look at details here. This area is from the medial, this area from the lateral. They are called the Italian arteries of Berlusconi and Casinari. So whenever you go in the world, you say the Italian arteries, people know what you're talking about. What are these Italian arteries? They are branches from the posterior aspect of the carotid, cavernous carotid. There's a branch called the meningiohypophyseal trunk, and those arteries are branches from the meningiohypophyseal trunk. So again, this is the cavernous carotid, and the branches of the meningiohypophyseal is there, and this is the inferior lateral trunk, which also supplies the tent. Carotid, the meningiohypophyseal trunk, and the Italian arteries, and the branch that comes from the inferior lateral artery going to the edge of the tent. So this is the whole picture covering the tent. You cannot go there without having solid anatomical knowledge of that area. There's also blood supply coming from other areas. This is your posterior cerebral artery tentorial branch, which people don't know much. In fact, lots of people don't know about its existence. Posterior cerebral artery tentorial branch. This here, by the way, is the branch coming from the vertebra. From the vertebra, it goes up. This is the branch from the posterior cerebral. It gives its tentorial artery. It is called artery of Davidoff and Schichter. And this is one of the cases where you can see artery of Davidoff and Schichter. So it is there for you to see. And this is the case that we just mentioned, the case of Dr. Habib Embolized. And these are the Italian arteries coming from the meningiohypophyseal branch, and the posterior aspect of the first curve of the carotid. Also, there is blood supply coming from the superior cerebral artery, meningeal branch. And in this case, this slide I borrowed from kindly for the courtesy of Dr. Farid Al-Adham, one of his cases showing this dural branch of the superior cerebellar artery, but in the text of this, not the film, the text of the dural fistula. This artery has a name. These are two brothers working in Germany, Holzschäger and Wilschager. That's the name of the artery. Artery from the vertebral artery, this is V3. And you can see the meningeal branch goes up. Another branch comes from the middle meningeal, the periphery of the tent. If you don't know, just leave the patient. Keep him in piece rather than in pieces. And this is the recurrent branch of the middle meningeal artery that goes through the basal foramen. Again, you have to do full knowledge of the tent, venous drainage, lots of tentorial sinuses, and most importantly is the vein of Labé. It will be in Norway.
Yeah, we're just trying to make the sound clearer, Dr. Sbeih. Someone in the audience mentioned it's not so clear. I thought it was me.
Hello.
That's good. That's good. How's that, Dr. Haneen? Is that better? Okay. Well, that's
Can you
good.
hear me now, Joe?
Yeah, that's better to me. Yeah, it's
Okay.
better.
So the knowledge of tentorial venous sinuses and the position of vein of Labé is very important, like this one. Lots of dural venous sinuses. You'll be operating here, so you should know. And vein of Labé also is very important. You should know the layout of the venous sinuses there. This beautiful view from Yazapil book showing the 3D venous structures, like this. Like this. So lots of venous sinuses. This is CT venography of the same patient, showing lots of dural sinuses, which I will show you in a minute. So we got the blessing from the anesthesia. They hated us for giving them such a horrible case. We put the patient in the sitting position, which we have done more than 1,000 cases of sitting position, and I'm proud to say that we've never lost a case for air embolism. People are afraid of sitting position because of air embolism. We are not afraid of air embolism. We are accustomed. We can treat all this, and we use all the stimulation and the navigation and the observation of all cranial nerves. So the patient in the semi-sitting position, because if he's not, this is neutral. This is in the setting, so you can get into this area. I did open so-called combined approach, supratentorial and infratentorial, because I could see in the MRI that the tumor is going through the tent. So here we are, the layout in the theater, and this is the scanning session, lazy curved session, and we'll do the occipital craniotomy, supratentorial, and we'll do craniotomy in the posterior fossa. So the idea is this. It is on the right side. We are on the right side. I would open the dura here. I will open the dura here so that I can go above supratentorial and below infratentorial. By the way, this is called combined approach for tentorial tumors, was described first back in 1991 by Shaker and Atom from Seattle. So this is the thing. This is the sagittal sinus, transverse sinus. I want to concentrate on here. This is the transverse sinus. I will open the dura to look here. I will open the dura to look here. And this is again the way to go supracerebellar infratentorial. So we did that. We opened the supratentorial. This is the occipital lobe. This is the transverse sinus. And its way to become the sigmoid sinus. And there should be a vein here, which is vein of Labé. So we open the dura infratentorial, open the dura supratentorial. I will show you the film and still pictures, and then we'll show you the video. You will understand the video better if you look at these still pictures. So, looking supratentorial, dura is open here. These are the basal veins of tentorial sinuses, and this is vein of Labé. And we are holding the edge of the dura to show you the veins. If you damage these veins, you'll get an infarction. So this is the tentorium from above, and here to see it from below. Okay, so now we proceed with the infratentorial. So this is the tumor. You cauterize the vessels on the surface. Now we are more confident because we have done embolization. Otherwise, it would be disastrous. Even with embolization, you will see how much bleeding we have. So you start taking the tumor from inside. Now, ideally, if I think this is hemangiopericytoma, I should take it in one piece. But because of the location, you can't. You have to accept the risk of going inside. And we are going, look at the blood. But again, this is sitting position, so blood is just flowing down, not hindering my vision. While if you do it in the concord position or whatever position prone, then you have all the blood inside. Sitting position is the best. But people are frightened to do it because they are not experienced. Look at the blood. That's with embolization. So, debug the tumor from inside and catch the upper edge, and then trying to separate the tumor from the tent. Gradually, I'm separating. Now I'm seeing the tent, edge of the tent, and the tumor is here also. So I separate the tumor from the tent. Gradually, this is the tent. This is not bone, this is the dura, the tent, and this is the tumor. Now look at this. The blood vessels on the surface are embolized, they're not bleeding, which is good. You can see the embolized vein. You have seen the slide that the professor showed you. It showed the embolic material inside the blood vessels. Proceed. Look at this blue color of the embolized vessels. So again, that tumor, you start to take it out with the ultrasonic aspirator. And now you can catch the edge of the tumor and start doing arachnoid dissection. As I keep telling for the junior staff, arachnoid is a membrane that you can catch with your surface and pull it away from the tumor towards the brain tissue. Then done, finding the lower edge of the tumor. Here is the petrous bone laterally. Removing it from the petrous bone laterally. Petrous bone, tumor. And every piece of the tumor you can excise, you excise. So this is the last piece here attached to the vitreous edge. And this very important blood vessels coming from ICA. I cauterize it, remove the tumor completely, and look at the cerebellum being relaxed completely, no pressure whatsoever. So let's see the video. We can show the video in 2D and 3D, but for the interest of our international audience, we cannot show the 3D, we'll just see the 2D.
Of course, you're going to compare views, huh? Okay.
Can you see, John?
Yes.
Okay. So as I said, this is after embolization and still bleeding. Embolization was helpful. But as Dr. Reed and Dr. Hazim said, the blood vessels are not only coming from the dura, as you may think, they are coming from the main arteries of the brain, the so-called parenchymal arteries. So holding the tumor, separating it from the pores. Again, you can see the transverse sinus pulsating. You can see vein of the brain. I'm elevating the occipital lobe to see those veins. And most importantly, I want to see whether the tumor has passed through the tent or not. I was lucky, it did not. So, in opening, as I said here, the supratentorial, transverse sinus is here. Back to the infratentorial, holding the tumor, finding the lower pole of the tumor, is the petrous ridge here. This is the tent. The tumor is actually attached to the tent and taking the tent with it up. Look at the blood vessels. Horrible. That's after embolization. Look at the bleeding. Using scissors to separate the tumor from the tent. Finding the edge of the tumor. This is the tent here. This is the tumor. Again, you can see the blue color of the blood vessels. Again, still terrible bleeding. You have to prepare 6-8 units to be ready because you never know what's going on. Especially that if any of the venous sinus is open when you are in the sitting position. So liberal preparation of blood and also more plasma, fresh frozen plasma. And my anesthesia colleagues here know that I would not start on the surgery without the blood being ready and theatre with the fresh frozen plasma. Having separated the tumor from the tent, now I want to separate it from the petrous edge. blood, every minute of the day. I'm looking again up to make sure that the tent is still intact. The tumor has pushed the tent out, but it did not go through. Which was that I was looking. Arachnoid section. Take the arachnoid away from the tumor towards the brain tissue. Because most of the blood supply of the brain comes from the subarachnoid arteries. Using ultrasonic aspirator, any part of the tumor you can remove out of your way. Of course, the blood is less now because you have devascularized the tumor. But look at this last piece, still bleeding. And this is the branch from the ICA. I'll put it on the move. Back to the area of the still this tumor here. And this is the branch that's going to the internal tissue canal, branch from the ICA. So I'm cutting the arachnoid away. So you can see here the suprameatal tubercle, the pressure nerve is here, and this is the artery from the ICA going into the external liver. This is where the tumor was attached to the tent. So remove the retractors and the cerebellum is relaxed. Don't need to do anything further. Okay, as I said, we cannot show you the 3D. We have the 3D screen and the 3D classes, but for the sake of our international audience, we cannot show you that. We do MRI the very first day. We finish, I think, about 11 o'clock in the evening. Next morning, MRI. Don't do CT scan. Those who are doing CT scan, they don't want people to see what we were doing. So this is the first MRI the following morning. Almost 7 hours after surgery, you can see that we have done a good job. No ischemic changes in the brain. And this is the patient. Recovered completely without any neurological deficit. And this is a neurosurgery, not a shunt, not putting screws in the back. This is proper neurosurgery, which lots of people do not understand. The Center for Radiation, according to the rules, she received radiation when Dr. Embolization and Musa from Cancer Center. She received, I think, 59 grades over 33 fractions. This is after radiation. She came to the clinic for visits. She was doing well. She remained well 5 years later. She went back to her normal life. And this is her MRI 5 years later. No residual, no recurrence. You feel you have done a good job. Everybody is happy. Then, 7 years later, recurrence. So you tell the patient, maybe we go again for surgery or for radiation. She refused any form of treatment, and we stopped at that. With this, I finish, and I thank you for listening. We're open for discussion. Any questions from our abroad audience is to be received. Okay, John? John?
Yes, do you want people to ask questions now, Dr. Sbeih?
Yeah. If you have any questions, we'll answer them, and then we'll have questions from the local audience.
Okay, the floor is open. Now is your chance to talk to Dr. Sbeih directly. Well, I guess we don't have anybody right now, Dr. Sbeih.
Okay, so we'll have questions from our people here in the auditorium. Any questions? Please.
Neural branches of the core, but mainly from the anterior spinal artery. So these as well, we have been trying to embolization. In the last slide, I was hoping that 5 years was negative, and then after the 7 years it came back because these recent studies, it has demonstrated that maybe embolization and surgery is associated with less recurrence rate, which is good. I mean, this is true. It is proved to be true, like in young people. Jordan, we have maybe because we work in a cancer center, but in the last 6 years there, we did 3 cases. So it's there, and we see the variant types, the very variable types. We see the spinal, we see the so it has 10 extra euro.
Questions with the professor?
I have a comment and a question. The comment, me and Dr. Ibrahim, we had 5 cases of hemangioperitoma since 2005 till now. So we still see cases, it's rare, but because Dr. Ibrahim gets the difficult cases, we really have nice collection of cases. And Dr. Ibrahim, as mentioned, it's a rare tumor. But the question about this patient, I noticed that although the last follow-up was 5 years, then 7 years, the tumor looks big. For 2 years, it grows so rapidly. It's really big. Was she symptomatic? And
She was asymptomatic, and then she got something.
she got something. But it seems that probably is going from grade 2 to grade 3 because to enlarge in such a short period means that probably it's bad.
Okay, any more questions? Very common extracranial. It's a moving part of the body. You would say something like 80% to 15% in the cranial, 5% in the spine. Extracranial and the chest and the liver and the legs, etc. So, in case our ENT colleague here is telling us that in the case of the severe terminal.
I just want to comment on the history of hemangioperitoma. Hemangioperitoma, it was a recognized tumors in the 80s and 90s. Then suddenly we are told that it is not a tumor anywhere. It's because we cannot call it hemangioperitoma, and we have to cancel this tumor from our literature. Then again, solitary fibrous tumor came in, and hemangioperitoma came in again, and they joined each other. And solitary fibrous tumor, when it started as a called solitary fibrous tumor. It's in the plural usually, but then we discovered that it is present everywhere in the body, and it's been attached to hemangioperitoma, and the value of genetics, because they have the same genetic, which is NAP2 STAT6 fusion in chromosome 12, which stands by STAT6 immunostaining. And this STAT6 came in the probably 2015, and I brought it to my lab in about 2018. And in cases اللي عملناهم مع Dr. Ibrahim, we did probably the last 2 cases with STAT6. The previous ones, we did not do STAT6. So part of the definitive diagnosis to do STAT6 to make sure that it is solitary fibrous tumor and hemangioperitoma, and it's present. It's considered sarcoma outside the brain,
present in many different organs, and we can diagnose it in every organ in the brain, in the human brain.
I remember when I was in London, there was a very famous program on TV called Mastermind. And famous person would interview and ask you questions you have to answer quickly. So if you are good, you can answer questions in a very short time. And there is a time period, say 2 minutes, and then there is a ring to stop. So if you start a question, you would say, although there is a ring with the bell, I will continue. You would say, I start, so I will finish. I'm quoting this, I start, so I finish, because I had a case of solitary fibrostone with hematocytoma and bicarbonate signs, the worst place ever. And I remember from A to Z, to bled and bled and bled, because you have to remove it all before you stop the bleed. So hematocytoma is a bad too. Any questions? Not, thank you for coming, and we will see you next week, next 2 weeks.
Okay, very good, Dr. Very good, Dr. Sbeih. Let me take you off the screen there. Okay, I really like the way you drew in other specialists, Dr. Sbeih. I forgot that you're one of the few people that does that, and it really adds to the completeness of a presentation. Okay, do you want a screen share or? I'm getting you. Okay, let me get you off there. Let me get you off the screen share. Share screen. Okay. Okay. I'm not stopping it. I'm trying to stop your screen share now. Okay. Abdallah, do you have a comment or question? Or anyone else in the audience? Perhaps I missed somebody. Yeah, Dr. Sbeih, can you just mention the people that you consulted? I'm not sure if we're clear on their names. Can you hear me okay, Dr. Sbeih? Hello, are you there, Dr. Sbeih? Oh, perhaps he signed out. I'm not sure what happened. Let me just check. I don't want to sign off too early. Can you hear me, Masad? Just a second. Okay. Yeah, I'm not sure if Dr. Sbeih, oh, there you are, okay.
Hello.
Okay, good. Yeah, Dr. Sbeih, I mentioned, I don't know if you heard me. Can you hear me okay now?
Yeah, I can.
Yeah, I don't know if you heard me, but I thank you for bringing in other consultants. You're one of the few people that does that. I think it really adds to the
Absolutely.
value of presentation.
Again, this is a teamwork. I work with radiologists, I work with anesthetists, I work with neurologists, so we're one team, and they should be there to give their opinion. So it gives me great pleasure that people like this.
I don't know if did we introduce them? Can you please introduce them or mention the people that you consulted? Because we kind of got caught up and we didn't really say who they are.
Okay, Dr. Hazem Haboub and Dr. Farid Al-Adham, both are interventional radiologists, and they had their degrees from the United States. They were licensed as interventional radiologists. And we consulted with our histopathology, Dr. Hussam Abu Farsakh, was also American boarded in histopathology. And as I said, John, before that, most people in Jordan, they have their higher studies abroad, either in Europe or the States. So this is a high level. Jordan is a hub for medical services in the area. We are a hub for mainly for first in the cardiac surgery and in the IVF, and then came neurosurgery. So we're proud of the level we have achieved and with the cooperation that we do.
Okay, can we expect to see multiple consultants on your future broadcasts?
Absolutely, this is the
Oh,
routine.
great, that's great.
Absolutely, yeah, sure,
That's the only one we're really doing it.
yeah, I know.
Okay, do you have any topic? I guess you don't know yet. For 2 weeks from today, we'll talk about it later.
No, I have decided to speak about the developmental venous anomalies in neurosurgery. What is a developmental venous anomaly and how we see it and how to treat it in cases like avernomas and in cases of gliomas. So I'll give my experience on this in 2 weeks' time.
Very good. Okay, we look forward to that. And thank you all the consultants and thank all the panelists and people that came to watch. And Dr.
Thank you.
Sbeih, thank you most of all. It's good to see that multi-consultant presentation. Thank you.
Thank you, John. Thank you very
Okay,
much.
bye-bye.
Thank you all. Bye-bye.